One of the themes that has come up, that has percolated during the day several times was standardization, whether it's standardization of how we measure liver fat, whether it's standardization of how we do diffusion for fibrosis, how we do standardization on Siemens and GE now with elastography, standardization for how we assess treatment response. And so what I wanted to talk to you about briefly today is an effort to standardize the method in which we interpret and report HCC in patients at risk for HCC, either due to cirrhosis or hepatitis B. CT and MRI, as we have reviewed today, play critical roles in the diagnosis and management of HCC. They allow us to detect, diagnose, and sometimes even stage HCC. And according to current guidelines, we do this without biopsy confirmation. So we are relying very heavily on imaging to get it right. Imaging helps to guide management. It helps to determine prognosis. It helps to assess treatment response. So many, many, many roles. And so you'd think that with all of these roles, we'd all be speaking the same language. We'd all be using the same criteria. We'd all be reporting cases in the same way so that the clinicians could clearly understand what we think is going on when we read our cases. But that's not the case. There is little or no standardization in these four critical areas. There's little or no standardization in the technique that we use, in the terminology and diagnostic criteria that we utilize, in the structure and content of the information that we put in our radiology report, or in the manner in which we collect data to start allowing us to develop registries at national and international levels. So little or no standardization for any of these things, and this has unfavorable consequences which are listed here. But let me just focus on this, terminology and diagnostic criteria. Because we don't have standardized terminology and diagnostic criteria, we use terminology inconsistently, not only in clinical practice, but think about this, also in our research studies. Our literature, it has different terminology. So if I read a paper from one investigator and I read another paper from another investigator and they're talking about hyper-enhancing lesions, I'm not certain that they're talking about the same thing. So it's very difficult for me to systematically review the literature or to have my minions systematically review the literature on my behalf because the language is inconsistent. Now, there have been many efforts to standardize the imaging criteria for HCC, and some of the highlights are listed here, which in the interest of time, let me not go over. Suffice it to say that many different international scientific societies or clinical networks have come up with management guidelines for HCC that include criteria on CT and MRI for HCC. Now, these criteria that are included in these management guidelines do represent important advances, as Dr. Weinreb mentioned in his very earliest talk at the beginning of the session, at the beginning of the day, but they have limitations. So let me focus on the two sets of criteria that you in the audience may be the most familiar with, which is the 2010 AASLD criteria and the 2011 United Network of Organ Sharing UNOS criteria. So let's look at these criteria. Both of these are criteria that are used to establish the diagnosis of HCC. The first thing to notice, so the ASLD criteria are listed here, and the UNOS criteria are listed here. Notice that the AASLD criteria are exactly the same, regardless of whether the lesion in question is between 1 and 2 centimeters, between 2 and 5, or greater than 5. The criteria are exactly the same. The UNOS criteria are different. The criteria are different if the lesion is between 1 and 2, different if it's between 2 and 5, and different again if it's larger than 5. Also notice that the AASLD criteria include this concept of washout, but do not include some of the features that are present in the UNOS criteria, such as the presence of capsule or the presence of growth. So the AASLD criteria and the UNOS criteria are not consistent with one another. Now, they have similarities. The similarities is that they both require, for the diagnosis of HCC, the presence of arterial phase hyperenhancement, and they both incorporate portal venous or delayed phase hypoenhancement. But that's where the similarities end. There are other differences. They actually use different terms to define arterial phase hyperenhancement, and they use different terms to indicate portal venous washout. So they're actually using different terms to mean the same thing. And as I mentioned earlier, UNOS incorporates additional features such as capsule and growth. UNOS uses more stringent criteria for smaller nodules than for larger nodules. Now, in addition to the discrepancies, they also have a few additional limitations which are listed here. Neither set of criteria, well, both sets of criteria essentially provide a binary classification. The lesion either meets or does not meet the diagnostic criteria for HCC. Now, this is an important advance. But as a radiologist, it doesn't help me that much because 95% of what I see in the cirrhotic liver is not something that meets criteria for HCC. So how do I, as a radiologist, deal with the plethora of other things that I'm going to see in the liver? These sets of criteria, although they represent important advances, do not help me as a radiologist with those things. Now, the other thing is that these criteria, as we'll talk about in a second, do not actually provide a lexicon of precisely defined terms. They also focus only on vascularity. They do not incorporate hepatobiliary agents. They do not include any criteria for treatment response assessment. They neglect vascular invasion by HCC. They neglect infiltrative HCC. And finally, they work very well when they are used by expert radiologists. And something else that I hope everyone in the audience realizes is that we have today some really excellent lectures on HCC, but they're all given by some of the leading radiologists in the United States. And the truth of the matter is that most CTs and most MRIs in patients at risk for HCC are not going to be read by the radiologists that presented to you today. They're going to be read by general radiologists who need to know something from everything from head to toe, and they need guidance in the interpretation of these extremely difficult examinations. Now, the two ones that I will focus on briefly are binary classification and the lack of a lexicon. So let's start with the binary classification. Why is that a problem? Well, if in fact in the liver all I had was either HCCs or nothing else, a binary classification would be fine. But in fact, this is the spectrum of lesions that one sees in the cirrhotic liver. And if we only dichotomize the diagnosis into diagnostic of HCC or not diagnostic of HCC, then I as a radiologist am not helped in how to interpret this plethora of lesions and pseudolesions that I encounter on a daily basis. Now let's see how this manifests itself looking at the ASLD guidelines. So let's focus on the left side of the ASLD guidelines. A lesion has been detected, it's bigger than a centimeter, and now a CT or an MRI is done. Now, if you look carefully at this algorithm, you will see that any lesion that is detected that does not have both arterial hypervascularity and venous phase washout eventually falls into the biopsy category. Well, what's the problem with that? Well, here is the differential diagnosis for lesions that might be seen in the liver that do not meet these ASLD criteria for HCC. So here's the differential diagnosis. Now, biopsying this lesion would be helpful. Diagnosing this lesion would be helpful. Do we really want to biopsy dysplastic nodules, cirrhotic nodules, hemangiomas, FNHs, pseudolesions? The answer is no. So there is an underlying inconsistency in this algorithm, because if you look at this algorithm and strictly apply it, anything that does not meet criteria for HCC and is bigger than a centimeter needs a biopsy. That's silly, but that happens. And so we need criteria that help radiologists in making a more sophisticated interpretation than either HCC or not HCC. And just to show you an example, this lesion here, which Dr. Weinreb would call a NAF, okay, this is nodule-like arterial phase hyperenhancement. There's a little nodule-like area here that hyperenhances and disappears on the delayed phases. This does not meet ASLD criteria for HCC. This lesion should be biopsied if you follow the ASLD criteria. But that's silly. We don't want to biopsy a lesion like this. The chances that this is HCC is only about 50%, and so this is a lesion that we probably simply want to follow. Another point, and this is the last point I want to make right now, is that there is not a precisely defined set of terminology. So both ASLD and UNOS rely very heavily on the presence of arterial hypervascularity, which is the term used by ASLD, or increased enhancement on the late hepatic arterial phase, which is the term used by UNOS. So we rely very heavily on these terms, but what is the definition of these terms? They don't make the definitions very clear. And just to illustrate that, let me just show you a schematic diagram. So if we saw this lesion here, I think we'd all agree that's arterial phase hyperenhancement. If we saw this lesion over here, going from a little bit brighter than liver to much brighter than liver, I think we'd agree that's arterial phase hyperenhancement. But what if we saw a lesion that goes from darker than liver to iso-intense to liver? Is that arterial phase hyperenhancement or not? Well, the criteria don't make this clear. So this is one of the most important features that we make to make the diagnosis, and this very elementary question, is this arterial phase hyperenhancement, is not well defined in the criteria. It gets even more complicated when you have just little chunks of the lesion that show different sets of enhancement. So the point is that we don't know what to do with these based on the existing guidelines, and so we need a lexicon that precisely defines the interpretation of such findings. Now, LIRADS is the Liver Imaging Reporting and Data System. It is a comprehensive system that addresses the entire spectrum of lesions from benign to HCC, including the lesions that end up not being HCCs and end up being cholangiocarcinomas. In the year 2012, LIRADS is applicable to patients with cirrhosis or at risk for HCC. It currently focuses on CT and MRI with extracellular agents, but an update is planned to incorporate hepatobiliary agents. Again, it addresses the full spectrum of lesions and pseudolesions, and it is the first system that is endorsed, that was developed by and endorsed by a radiology society. The aims of LIRADS are listed here, but I'm really running out of time, so let me not get into all of the aims right now. And I want to just conclude with my last thoughts. So what I would like to articulate is a vision that in the future there can be a unification of the ASLD guidelines, the UNOS OPTN policy, and LIRADS, and here is an example of how this vision might work. So rather than having a management guideline in which the management and the interpretation of a lesion is established by a non-radiology organization such as the ASLD, why not have a management guideline in which a lesion is seen, the lesion undergoes multi-detector CT or MRI, that lesion is then given a LIRADS categorization, and then depending on the LIRADS categorization, a management outline is interpreted. So the idea would be that we would create management guidelines by combining the efforts of radiology societies and clinical surgical societies. The clinicians and the surgeons can decide what is the optimal management, but incorporated into that management are criteria that are developed and validated by radiologists. If anyone has any more questions about LIRADS, I'd be happy to discuss it during our wine and cheese session. I don't think time will permit tomorrow, but if anyone is interested, I would be willing to show you sort of a provisional working version or a provisional version of the LIRADS version that's going to be released later this year. At any rate, I think with that, I would like to thank you very much for your attention, and I will turn the floor back over to the moderators.